So in endocrinology part 2, we're going to be focusing on the thyroid gland, parathyroid gland, as well as the adrenals, or as some textbooks like to refer to them as the suprarenals, but I don't like that term. I like adrenals. Bless you. So this is a case of a thyroid disorder. This person has a goiter, and goiters are going to be associated with certain forms of hypo and hyperthyroidism, which we'll go into today. Now, this is a review of a lot of the stuff that you guys already learned in A&P, but this is the HPO axis. So you got the hypothalamus, which releasing hormones as well as inhibiting hormones. Okay, then you go down to the level of the pituitary gland. You have both your anterior and posterior pituitary. The majority of the hormones are going to be released from your anterior pituitary. There's 2 of which that are going to be from your posterior pituitary, ADH and oxytocin. Are ADH and oxytocin produced in the posterior pituitary? They're not. They're produced in the hypothalamus, and then they get stored in the posterior pituitary until they get released afterwards. So ADH and oxytocin are those 2 that get stored in the posterior pituitary. The rest are all in the anterior pituitary. And then you have your target organ. So that's what the HPO axis is. So today, we're going to be talking a lot about thyroid. So at the hypothalamus, it's TRH, thyroid releasing hormone, TSH at the pituitary, thyroid stimulating hormone, and then your end organ is going to be your thyroid gland. We're also going to talk about cortisol and as well as aldosterone too, when we get into like Addison's, Cushing's disease, things like that. CRH is your corticotropin releasing hormone. Then you have ACTH from your pituitary, adrenocorticotropic hormone, and then your adrenal gland is going to be the target organ, the adrenal cortex. And that's where you get the release of things like cortisol as well as aldosterone, which we'll talk about when it comes to Cushing's disease later on. We already talked about GH, which is your growth hormone. We're not going to be, we already talked about prolactin as well. You know, galactorrhea with a person with a prolactinoma. So we already covered those. And we're not going to be talking about oxytocin or ADH today. So let's first start by getting into thyroid gland disorders. And the big thing with the hormones is it's good to know where they come from, right? Especially when it comes to primary versus secondary versus tertiary hyperthyroidism or hypothyroidism. Because if you have a primary disorder, that's going to be at the level of the target organ. So like, for example, primary hyperthyroidism would be at the level of the thyroid gland itself. Secondary hyperthyroidism would be maybe an adenoma hypersecreting TSH, thyroid stimulating hormone from the pituitary. Tertiary would be at the level of the hypothalamus. So it's good to know at what level each of those hormones are getting released. And the releasing and inhibiting hormones are going to be associated with the hypothalamus. Then you have your stimulating hormones that are going to be coming from your pituitary gland. So it's good to know those levels of the HPO axis. It's going to be really important for you to be able to figure out if it's a primary, secondary, tertiary disorder. So yeah, be familiar with where the hormones come from. It'll help you a lot. All right, so let's talk about the thyroid gland. Does anybody know what the term is for what's going on with this lady's eyes? Yeah, good. So it's exophthalmos, right? And so when somebody has exophthalmos, one of the ways that you can like look for that in a clinical setting, I mean, for this person, it's obvious, right? But one thing you could do, you can like look at them from above, and if you can see their eyes, if you're looking at them from above, then that's exophthalmos, right? But of course, you don't have to do that. If you saw this person, you would be like, okay, this person's eyes are just bugging out. This person definitely has exophthalmos, which is going to be associated with what type of thyroid disorder? Do you guys remember from A&P? Yeah, which is Graves' disease. Good. This is one of the hallmarks of Graves' disease, right? It's going to be exophthalmos, which we'll talk about in a moment. So hypothalamus, you get releasing hormones. So for the thyroid, TRH, thyroid releasing hormone from the hypothalamus. It stimulates the anterior pituitary to release TSH, or thyroid stimulating hormone. And then the final end organ is going to be the thyroid gland. And you're going to be seeing 2 major hormones released, T3 and T4. Um, we'll talk about the difference between T3 and T4 in a moment. But one of the big differences is going to be the numbers of iodine. So with T3, it's 3 iodines, triiodothyronine, versus T4, it's going to have 4 iodines, and that's going to also be referred to as thyroxine. This is also a drug that you can take, right? Thyroxine. If you have hypothyroidism, you're going to be taking thyroxine as as a treatment for that. What does thyroid hormone do? One of the major things it does, it helps regulate metabolism. So it's got a calorogenic type of effect. It's going to increase your metabolic activity. So if you have hyperthyroidism, you're going to have a hyper metabolism, right? So you're going to lose weight as a consequence. You're also going to be really sensitive to heat, right? So you're going to feel like it's really hot all the time. So that's going to be temperature intolerance, especially with heat when you have hyperthyroidism. Hypothyroidism, it's the opposite. You get temperature sensitivity to cold, right? You feel like it's cold all the time. And you also are going to have reduced metabolism, and so you're going to see weight gain in a patient with hypothyroidism. Catecholamines are also going to be released as a consequence of thyroid hormone. So if you have lots of T3 and T4 floating around your body, you're also going to feel like you're in a sympathetic state all the time. So you're going to feel that fight and flight, right? You're going to have norepinephrine, epinephrine, catecholamines being released in abundance or in excess. You're also going to have effects at the heart, right? So if you're hyperthyroid, your heart rate is going to be accelerated. You're going to be tachycardic. So it increases your contraction and heart rate. And then in terms of development, you need to have thyroid in order for the child to develop properly. What's a condition of a person who does not have enough iodine during fetal development and they don't have enough thyroid hormone? Called cretinism. So if a person has cretinism, that means that they didn't have enough iodine during developmental years, and so they're going to have all sorts of issues. Some of which are going to be cognitive, right? They're going to have reduced cognitive ability. They also are going to have some interesting looking facial features, which I have a slide that talks about cretinism a little bit later here. So this would be an example of a person with cretinism. So short stature. If you were to do an IQ test on this person, they would probably have like reduced IQ, right? So they're not going to have full cognitive development as they otherwise would. So T3 and T4, that's going to be the major goal of thyroid hormone release. It's basically going to affect like almost every cell in the entire body, right? And the way thyroid works is in a couple different ways. You can see it enter into the cell, so it can affect receptors in the cytoplasm. It's going to stimulate ATP production at the level of the mitochondria, right? That's how you get elevated metabolic activation with thyroid release. You're also going to see stuff happening at the level of the nucleus, and if you have too little thyroid, you're going to see cretinism. So this map over here shows the distribution of thyroid diseases, right? So here in the West, as well as other parts of East Asia, South America, you're going to get reduced thyroid issues due to iodine, because in the West, we've fortified what in our diet with iodine? Salt, exactly. So our sodium chloride is also going to have iodine in it too. And so it's fortified, so it helps to prevent cretinism, it helps to prevent hypothyroidism, things like that. Parts of the world that don't really have great access to like nutrients and things like that, they might be economically underdeveloped. Those areas, you're going to see a higher rate of diseases like cretinism. You're going to see higher rates of thyroid disease in those areas. So T3 and T4, what's the major difference? So T3 and T4, T3 is way more potent than T4. So T3 is, you can think of it as being kind of like the active form. It's really potent, however, it's not going to last very long. So when a person is taking drugs to like replenish their thyroid hormone, they're going to take thyroxine. Thyroxine is T4. It's going to last longer in the body. It's not as potent, but it's going to last longer, and then it can get converted to if you remove one of the iodines, then it would turn into triiodothyronine, so that would become more active. Those are the major differences between T3 and T4. Types of hyperthyroidism. So here are the three major types, or three major categories. Primary, secondary, tertiary. Right? Those are the three major categories. Primary is going to be at the level of the thyroid gland itself. Right? You're going to see elevations or reductions in T3 and T4 if it's a primary type of disease. For primary hyperthyroidism, you're going to see elevated T3, T4. Then if you look at the rest of the HPO axis, because the hypothalamus and the pituitary gland are trying to regulate thyroid release, you're going to see reductions in TRH and TSH, right? Because the hypothalamus and pituitary are saying, well, there's way too much T3, T4. We don't need any more. But because you have a primary issue, maybe it's like a tumor or something like that, then you're going to see too much T3, T4, and then you're going to see the hypothalamus and the pituitary try to compensate for that. One great example is going to be Graves' disease. Right, so Graves' disease, we'll talk about that a little bit later. It's an autoimmune disorder that affects the thyroid gland. You get massive release of T3, T4. With Graves' disease, you're going to see goiter, and then you're going to see the exophthalmos. Right, so you're going to see the bulging of the eyes as well as goiter, which is excessive amounts of tissue accumulation within the neck around the thyroid area. Secondary hyperthyroidism, that's going to be pituitary. And so your TSH is going to be elevated. T3, T4 is also going to be elevated, but the hypothalamus is trying to put the brakes on. And the hypothalamus is going to have reduced levels of TRH. Tertiary is at the level of the hypothalamus, and that's where you get elevation of everything. Elevated TRH, TSH, and T3 and T4. Now, Graves' disease is going to be one cause of hyperthyroidism. Again, not the only cause. You can get like toxic nodules. You can get tumors that can release excessive amounts of T3 and T4 as well. But Graves' disease is going to be one type of hyperthyroidism, and it's going to be autoimmune. And you're going to have immunoglobulins that basically stimulate the release of T3 and T4. What's going to happen? You have excess metabolic activation, right? Your temperature is going to be really high, so you're going to have heat intolerance. The person's probably going to look skinnier, right? Because they're going to be losing a lot of weight. They're going to be tachycardic, right? Their heart rate's going to be elevated. What else might they be feeling? Like mood-wise. Yeah, they might have anxiety, right? They might have anxiety. They might also might even see like a tremor as well. So all those things you will see in hyperthyroidism. So TSI, that's your thyroid stimulating immunoglobulin. That's what's actually causing the elevation of T3 and T4. What's going to happen with your TRH levels in a patient with Graves' disease? Up or down? It's going to be down. Good. What about TSH? Up or down? It's going to be down, right? TSH is going to be reduced because your pituitary gland is also trying to put the brakes on, right? There's too much T3 and T4. What about T3 and T4? It's going to be up. Good. Now, does this person have a goiter? Yeah? So this person does have a goiter, right? So Graves' disease, you will see goiter formation. So that thyroid stimulating immunoglobulin, TSI, is going to cause goiter formation. So you're excessively stimulating the thyroid gland. Whenever you excessively stimulate the thyroid gland, you're going to get a goiter formation. A goiter is basically just like enlargement of the thyroid tissues. Yeah, and you get it can become really nasty, big nodules too. So there's gradations of severity, but it's basically an enlarged mass at the level of the thyroid gland. All right, so who gets these? It's going to be more common in women than men. It is the most common cause of hyperthyroidism, especially between the ages of 20 and 40. And here's the major thing that's involved. It's going to be your thyroid stimulating immunoglobulin, or TSI. TSI binds to those TSH receptors. It's going to cause excessive amounts of T3 and T4. So it's going to cause excessive activation. And then you're going to get everything involved with hyperthyroidism, all those different signs and symptoms, right? Temperature intolerance, loss of weight, tachycardia. You'll see this especially in smokers, the exophthalmos. Exophthalmos, you get the bulging of the eyes, right? Because the eyes are being involved, you can also see things like diplopia, which means double vision. You're going to see edema around the eyes. And then down in the lower extremities, you're going to see the pretibial myxedema. So if you look at the tibia, that's going to be right below the knee, you might see thickening and discoloration of the skin that's affected. Right, so that's going to be one of the hallmarks of Graves' disease as well, is pretibial myxedema. Myxedema is just a fancy term for just swelling, right? I'm going to show you some other images of what myxedema looks like. But for Graves, it's specifically going to be around the tibia. And you're also going to get that goiter formation. How do you test for this? So you can just run those simple basic metabolic panel, the simple labs, looking at your T3, T4 levels, look at TSH. If TSH is low, then you know it's going to be at the level of the thyroid gland. You also can look for the thyroid stimulating immunoglobulins. So if you see elevated TSI, that's another sign for Graves. Radioactive iodide uptake. So that's radioactive iodine. You give a person an isotope of iodine, and if you're able to do a scan and you see excessive amounts of uptake at the level of the thyroid gland, then you know there's something going on at the thyroid. Things that you can do to treat this. Propylthiouracil is one drug that you can use to help reduce thyroid production. But if it's really bad, you can give the person radioactive iodine treatment, and that's a radioactive ablation. What other parts of the body might get affected by this? Radioactive iodine. It's a trick question. No other parts of the body is going to be affected by it. Radioactive iodine is only going to destroy the thyroid gland. The thyroid gland is the only thing in the body that basically uses iodine. So radioactive iodine is actually a very safe procedure. It doesn't actually affect any of the other parts of the body. Unfortunately, however, if you wipe out the thyroid gland, what does the person have to do now? They have to take pills for the rest of their life, right? They have to take exogenous thyroxine for the rest of their life. So hormone replacement surgery is going to be replacement therapy is going to be important for those patients. You could also go in and surgically remove the thyroid gland if it's severe enough. So these are some really severe cases of exophthalmos. Like, I've never seen anything like that before. That's just absolutely wild. But what's going on? It's part of the immune process. The immunoglobulins are starting to attack muscles and fat around the eyes, and that's what's causing the eyes to actually protrude out, resulting in exophthalmos. So if you were to do the radioactive iodine scan, this is what you would see. So this is a normal thyroid gland, normal lighting up on the scan. This is massive amounts of uptake on a person with Graves' disease. So you get lots more going on in terms of iodine uptake. Here's your pretibial myxedema. Pretibial myxedema, also referred to as thyroid dermopathy, is where you have lesions of the skin resulting in deposits of hyaluronic acid. And that's going to be the major underlying cause of pretibial myxedema. So what happens if the thyroid goes completely haywire and out of control? You might see a person go into a thyrotoxic storm. And this is extremely life-threatening. Those people can die really rapidly if they're not treated properly. This is going to be spontaneous for the most part, but it can also be associated with infection. Other things too can cause it, surgery, dialysis, but usually it's going to be infection that throws a person to a thyrotoxic storm. So they go into hyperthermia, high temperatures, their heart rate goes really rapid, right? So they become tachycardic, they can become delirious, and they can eventually develop nausea, vomiting, diarrhea, etc. So that's Graves' disease. Now, other things that might cause hyperthyroidism at the level of the thyroid gland could be a toxic nodule. You can get solitary toxic nodules. You can also get multinodular goiters as well. These are usually going to be benign, but they can sometimes be malignant as well if it's like a severe form of thyroid cancer. These are going to be the second most common form of primary hyperthyroidism. With this, you're going to see hyperthyroidism, but you're not going to see any of the other stuff. You're not going to see the exophthalmos. You're not going to see the pretibial myxedema, because those are going to be related to the immunoglobulins, right? So if you have the thyroid-stimulated immunoglobulin, that's when you see the eyes involvement, exophthalmos, and then the skin involvement with the pretibial myxedema. Again, the same type of test, right? You're going to see T3, T4, TSH is going to be low. If you test for TSI, you're not going to see TSI, the thyroid-stimulating immunoglobulin. You might see a nodule. If you're palpating the patient's neck, you might be able to actually feel for nodules on there. You could do an ultrasound to look at the thyroid. Do that iodine scan. So if you did this type of iodine scan right here with an isotope of iodine, you're going to see those nodules light up. You could also do a biopsy too. What's up? What's up? Yeah, you would see goiter with Graves. With this, you would not necessarily see a goiter. So with Graves, with goiters, like a goiter, like an actual goiter, you're going to see a nodule, right? So it's going to be like a palpable nodule, but it's not really like a goiter per se, compared to with Graves' disease. You actually see these massive goiters. I mean, it's still considered like a nodular goiter, but it's not going to be like massively enlarged like you would see with Graves' disease. So you would see like these little tiny nodules. So you'd palpate a very small nodule at the neck. For a hot nodule, what's going on over here? So with a hot nodule, you're going to get the uptake of the radioactive iodine. This should say hyperthyroidism over here. Versus a cold nodule, you're going to see no uptake. So scratch this off, write down hyperthyroid right over here. So that shouldn't say hypothyroid. Actually go in there and let me fix it from my end. Let me do a screenshot so I remember. Give me 2 seconds here. Okay, cool. So hot nodule, you're going to see a lot of uptake of radioactive iodine. And again, this is at the level of the thyroid. It has nothing to do with TSH, right? Cold nodule, you're going to see very little uptake of iodine. And so that would be causing more hypothyroidism. Hot nodule, hyperthyroid. Cold nodule, hypothyroid. So cold nodule, you're not getting as much uptake of the iodine. That's why it's cold. It's going to show up cold on a scan. Versus hot, you're going to see a lot more uptake of radioactive iodine. And then if you saw a warm nodule, that's normal. That's normal uptake of iodine. So here are the different types of things you might see on a thyroid scan. So here's your Graves' disease. The entire thyroid gland is being lit up, right? Stimulated by that TSI. And then multinodular goiter, you're going to have a bunch of different tiny nodules affecting the thyroid gland. And then, so here's your multinodular goiter again. You could also see toxic adenomas. That would be like one little region. If you hear the term adenoma, that's referring to a gland, right? It's going to be a glandular type of tumor. Yes. What? Yeah, so these are radioactive iodine. So these are different isotopes of iodine that you can actually look at in a scan. And so if you were to give the person normal iodine, you wouldn't see that right on the scan. It has to be a radioisotope. And so you would see what parts of the thyroid are going to be taking up a lot more iodine. It's like hot nodule, Graves' disease, things like that. What's up? Yes. Different nodules, different areas. Right. Yes. Exactly. And if it's a hot nodule, you're getting a lot more uptake of iodine. Cold nodule, reduced uptake of iodine. Cool. All right, let's do a little case presentation. Short and sweet. So you got a 52-year-old female, presents with fatigue, weight gain, cold intolerance. She is found to have a goiter. Blood tests reveal elevated TSH and low levels of T4. So this is primary hypothyroidism. If this was an autoimmune disease, what do you guys think this would be? This is not Graves'. Graves' is hyperthyroid. This is Hashimoto's disease. So this would be a person with Hashimoto's disease. So Hashimoto's, again, autoimmune disorder, but instead of inducing the thyroid gland to secrete T3, T4, this is doing the opposite. It's causing hypothyroidism. And so that's why you would also see elevation in TSH, because now the pituitary gland is doing everything it can to try to stimulate the thyroid, but the thyroid's unable to actually to produce any T3, T4. So this is Hashimoto's autoimmune thyroiditis. How do you treat this? You give the person levothyroxine. Yeah, that's like the main way. You just do supplementation for those types of patients. So this would be a great example of primary hypothyroidism. So what do you see with primary hypothyroidism? You're going to see reduction in T3, T4, but everything else is going to be elevated. TSH and TRH are both going to be elevated in those types of patients. So we talked about the autoimmune type, so that's going to be Hashimoto's. Other things that can cause hypothyroidism. If you don't have enough iodine in your diet, that can cause hypothyroidism. Surgery. So if you had a thyroid removal, a thyroidectomy, right? Or if you had the radioactive ablation, then that would cause hypothyroidism, right? And then you have to supplement. Just radiation exposure in general, right? If you're doing a lot of radiology work, you're going to have to wear like the lead vest. You also have to wear the lead little neck cover, right? And the lead neck cover is going to protect your thyroid gland because the thyroid gland is super, super vulnerable to radiation. Drugs can also cause this too, right? So propylthiouracil, that's used to treat the hyperthyroidism. Potassium iodide can affect it. People that take lithium, you might see hypothyroidism with lithium. And amiodarone is an antiarrhythmic drug that affects potassium channels. That can also cause hypothyroidism too. Contrast? I am not fully aware of all that with radiology. So with contrast, if they have an allergy to iodine, that might affect their ability to get contrast. I can't speak on that. I don't know I don't know anything about that. What was the other? Was another part to that question? I have I have absolutely no idea how that would affect their ability to get contrast. I'm sorry, I can't answer on that. As usual, look it up and let me know if there's something that I should include in my lecture slides. What's up? That is such a great question. I have no idea whatsoever. It's just usually those diseases do affect women more. I don't know. I don't know why. Yeah, beats me. Luck of the draw, genetics. I don't know. So with hypothyroidism, you see the opposite, right? So reduced metabolic rate. So BMR is your basic metabolic rate. So you're going to get weight gain, fatigue, lethargy. Your heart's going to be slow. Your blood pressure is going to be low. You're not going to be tolerant to cold. You also see hair change. You do see hair change in both hyperthyroid and hypothyroid. So you can have change of hair, like it might become more like flat. Some people experience hair loss. Like that's one of the major consequences of taking even like drugs like levothyroxine. Some of those drugs can actually cause changes in hair, including hair loss. The myxedema, that's where you have edema of connective tissues. That can happen in different parts of your body, face, hands, feet. I'm going to show you some images of what that looks like. If a person goes into a myxedema coma, that is very rare. that's basically where like everything kind of starts to shut down, right? Their heart rate is really low, their temperature is really low, just not a good situation. They get low sodium as well. Blood pressure is not that great. So again, there's going to be primary, secondary, and tertiary hypothyroidism, and really depends on where it's at. If it's at the level of the thyroid gland, that's primary. Right? We already talked about Hashimoto's. That's going to be a very common cause of hypothyroidism. And what's going on with Hashimoto's? These are the different antibodies that are attacking the thyroid gland. So you have anti-thyroglobulin antibodies, anti-thyroid peroxidase antibodies, and anti-TSH receptor antibodies. Each of those can cause Hashimoto's disease. Secondary hypothyroidism would be at the level of the pituitary. The pituitary gland is basically failing. So you could see this, for example, in a patient that maybe had like a pituitary adenoma removed, right? There's a condition for women when they're delivering a baby. It's called Sheehan syndrome. And Sheehan syndrome is during labor and delivery, if the woman loses way too much blood, that can actually kill the pituitary gland. You're basically getting hypoxic injury and cell death to the pituitary. So Sheehan syndrome, you would see like global reduction of all the pituitary gland hormones, including TSH, right? And so if you had a pituitary issue, that's secondary. Then tertiary would be at the level of the hypothalamus. You could get that with like cancers. You could get that with trauma. So lots of things can cause that. So Hashimoto's disease, make sure you're familiar with these different antibodies. So you got your anti-thyroglobulin, anti-thyroid peroxidase, and anti-TSH receptor. And that is your primary hypothyroidism. Let's see if this video is worth watching. Sure, it's short and sweet.
Have you noticed that your neck seems swollen lately? You could have a condition called Hashimoto's thyroiditis. The thyroid is a small butterfly-shaped gland in your neck that produces hormones, chemical messengers that regulate many organs and functions in your body. A thyroid imbalance can cause problems throughout your body. Hashimoto's thyroiditis is an autoimmune disorder which causes the immune system to attack the thyroid so it is unable to produce the hormones our body needs to function properly. This can eventually cause hypothyroidism and symptoms like these. Hashimoto's thyroiditis is the most common thyroid disease in the United States, affecting over 10 million people. It runs in families, and women are 7 times more likely to suffer from this disease. Hashimoto's thyroiditis progresses slowly over many years, and many people don't know they have it. If you just aren't feeling right or your neck is swollen, Hashimoto's thyroiditis could be the cause. There is hope and help. Your healthcare professional can determine if you have Hashimoto's thyroiditis or another type of thyroid disorder. You can learn more at ace.com/thyroid. Maybe it's time to think about your thyroid.
All right, sounds like a commercial to me. So I just looked up why women get thyroid issues more often. So according to Bumrungrads International Hospital, I don't know if I pronounced that correctly, women have a more vigorous immune response than men, which unfortunately makes them more prone to autoimmune diseases, including Hashimoto's thyroiditis and Graves' disease. So there you have it. That's why it's apparently more common in women than men. I have no idea. Why do women have a more vigorous immune response? You're making me go down a rabbit hole. I don't know, man. Genetics, yeah, genetics. Dang it, Mendel. If you didn't come up with genetics, then none of this would be happening, right? All right, Hashimoto's thyroiditis. As I mentioned, it's going to be one of the most common causes, autoimmune, mostly in women over men. You test for TSH and T3, T4. T3, T4 would be what? Up or down? Down. TSH would be what? Up. Good. TSH would be elevated. And then these are your antibodies. Anti-thyroglobulin, anti-thyroid peroxidase, anti-TSH receptor. And this is what's happening at the cellular level. So you have your your T cells and your B cells, right? So your B cells are what produce immunoglobulins once they turn into plasma cells. With Hashimoto's, those plasma cells are secreting those antibodies that are basically destroying the thyroid gland. So that's going to cause reduced T3, T4 release hypothyroidism. Versus with Graves' disease, your plasma cells start to secrete thyroid-stimulating immunoglobulin, and that stimulates the thyroid to release T3, T4. So those are the underlying mechanisms of Hashimoto's versus Graves' disease. This is myxedema. Myxedema is, swelling, basically. Swelling of different areas, eyes, face. It can happen to animals too. A lot of diseases that affect us can also affect our pets. So this was when the dog was actually normal sized, and now this is the dog looking like a meatball. So sad. Yeah. And then for these, it looks like this is before and after treatment for those patients. So you can actually reverse the myxedema if you treat it properly. Hypothyroidism. So we talked about the different causes, autoimmune versus other things. If you don't have enough iodine, that's going to also cause hypothyroidism. If you don't have enough iodine, what is that? Primary, secondary, tertiary? Primary, right? So it's going to be primary hypothyroidism. What would your T3, TSH and TRH look like? It would be, both of them would be elevated, right? So we already talked about all this stuff with the decreased body temperature, metabolic rate, etc. Now, this is a person who's born with cretinism, right? So they're going to have different types of facial features. They're going to have retarded physical and mental development. They're going to have bone development delays. They're going to have poor tooth development. They're going to have neurological damage. They might be a little bit like lethargic, apathetic, dull. Their tongues are going to be enlarged for whatever reason. Thick skin and lips, and they're going to have a broad-looking face and a flat nose. So that is congenital cretinism that is due to iodine deficiency. And by the way, the term cretin is also used as a derogatory term against people that are kind of mentally deficit. So don't use that term. It's not very nice to call somebody a cretin. Only use it in medical application only, please. Goiter formation. So what's going on with goiters? So you have irregular cell growth that forms these lumps. And the most common cause of goiters in the world is going to be due to iodine deficiency. That's the major cause of goiters. And goiters can vary in severity. They can be pretty mild, or they can be very dramatic. I mean, this looks like a parasitic twin growing in this person's neck. So pretty massive goiter enlargement. Like, look at those. Those look like grapefruit-sized balls. Just absolutely massive goiters for this poor lady. And you can get goiters surgically removed if it's severe enough. So, all right, let's do some charts. Let's talk about hyperthyroidism and then thyrotoxicosis. So primary hyperthyroidism. What's your T3, T4 going to look like? Oh, I started with TRH instead. TRH is going to be low with primary hyperthyroid. What about TSH? Low. What about T3, T4? High. Good. Is there going to be a goiter with this patient? So yeah, so think about like, oh, dang it. I need to fix this animation. So that would be an example of like Graves' disease, right? So primary hyperthyroidism, Graves' disease, you would see exophthalmos, you would see pretibial myxedema, and you would see goiter formation. All right, we'll go into that afterwards. Secondary, where are you going to see with your TRH at the level of the hypothalamus? Going to be down. What about TSH? Up, right? TSH is going to be up because now it's at the level of the pituitary gland. You might have like a hypersecreting pituitary adenoma. What about T3, T4? Right, it's hyperthyroidism, so obviously T3, T4 is going to be elevated. Tertiary, what's happening at the hypothalamus? High amounts of TRH. What about the pituitary? High. T3, T4, high. All right, now let's talk about goiters. So you get what? That is not. That's Graves' disease. Hold on a second. I think I need to fix this. Let me go over this later and get back to you and make sure that these are correct. I think I might have messed that up. So let me do another screenshot. Just be patient with me. So I will come back to this and I will look at this later and make sure that these are correct. Because primary with Graves' disease, you would see goiter formation. So that's embarrassing. Let me move on. So don't worry about the goiter formation from that last slide. I'll recap that afterwards. All right, hypothyroidism. Primary. What's going on with TRH? TRH is going to be high, TSH is going to be high, but your T3, T4 is going to be low, right? So what's a good example of that? Hashimoto's would be a good example of that. Also, iodine deficiency would be a good example of that. Secondary hypothyroidism, and you do see a goiter with that as well. Secondary hypothyroidism. Are you going to see any changes with TRH? TRH is going to be what? High or low? It's going to be high. TSH is going to be what? Low. Good. T3, T4 is going to be low. Do you think there's going to be a goiter with secondary? There's not going to be a goiter. What about tertiary hypothyroidism? TRH is going to be low, and then everything else is going to be low, and there's not going to be any goiter formation as well. Yeah, so the TSH is trying really hard to stimulate the thyroid gland, and because of all that attempt at stimulation, you're going to start seeing enlargement of the thyroid tissues. So that's why you see a goiter with primary hypothyroidism. I'm going to have to go back to that one slide and fix it. So I'll get back to you guys on the other one. It's kind of embarrassing. All right, here's another chart, some practice questions. So what would be going on with A over here? So everything is high, right? So is that going to be primary, secondary, tertiary? Good. So it's going to be tertiary hyperthyroidism. T3 and T4 are low. Everything else is high. There's a primary hypothyroid. What about this? What about C over here? Secondary hypothyroidism. What about D? What's going on over there? Everything is low, so it's going to be tertiary versus E. The only thing that's low is TSH, right? T3, T4 is going to be high. What's going on over here? So is that hyperthyroidism? That's hyperthyroidism, right? Primary, secondary, tertiary? Primary. What about F? Hyperthyroidism, level the pituitary, so that's secondary hyperthyroidism. Awesome. All right, let's make some other predictions here. Did you want me to go back to that? No? Okay, cool. All right, what's going on with weight changes with hypothyroidism? So it's going to be weight gain. What about hyperthyroidism? Oh, we didn't. Let's focus on hypothyroidism. Heart rate is going to be reduced. Blood pressure, down. Temperature, down. Temperature intolerance. So they're going to be intolerant to cold temperature. What's their mood going to look like? They're going to be lethargic. They're going to be tired. They're going to have like a downtrodden mood. What's going on with their bowels? Diarrhea or constipation? Yeah, you're going to see constipation. All right, now, hyperthyroid. Weight change. Weight loss. What about heart rate? Up. Blood pressure. Up. Temperature. Up. Temperature intolerance to heat. They can't stand the heat. You got to get out of the kitchen. What about mood? Anxiety, right? They're going to have a lot of anxiety. They're going to feel excessively energetic. Diarrhea or constipation? They got the runs. Yeah, so they got diarrhea. All right, so here's another chart just comparing and contrasting hyper to hypothyroidism. Yes? You're talking about this one? So temperature intolerance, they're going to have cold intolerance. So decreased decreased cold tolerance. Yeah, so it's cold intolerance. Let me fix that. They're going to have heat intolerance with hyperthyroidism. They're going to have cold intolerance with hypothyroidism. With all these mistakes. Goodness gracious. A crazy week. All right, subacute de Quervain's thyroiditis. Now, this is going to be inflammation that is secondary to a viral infection. Could be different types of viruses, but it could be flu, cold, sinusitis, etc. And you're going to get pain in the neck and tenderness. You're going to get fever, malaise because of the symptoms of the actual viral infection. You don't get myxedema. So the way that it progresses is that over the brief period of time, you're going to see reduced, you're going to see hyperthyroidism. So you're going to see reduced TSH from the pituitary, right? The thyroid itself is going to be hypersecreting. So at first, you're going to see a lot of T3, T4. So that's going to be at the initial onset. Then, as it progresses later on, then you're going to start seeing reduced production of your T3, T4. And then if you were following this chart here, the blue line is the actual thyroxine, right, T4. It dips at the end. You get reduced production. But TSH is going to try to come in to correct the reduced T3, T4. So you're going to get elevated TSH after a few weeks. And then you can test using your standard T3, T4, TSH, radioactive iodine uptake. And then because it's a viral infection, it's dealing with like inflammation, you can just give them NSAIDs, aspirin, things like that can help to clear up de Quervain's thyroiditis. Any questions? All right, let's continue on. If I have time, we'll go back to Module 8, Part 2, quizzes, questions. So if you don't have time, I want you to do this on your own. But let's move on so we can cover more ground. All right, let's now talk about the parathyroid gland. Parathyroid gland is going to be, as the name implies, adjacent to, right? Para means next to. So parathyroid, the glands actually sit on the thyroid gland itself. Generally speaking, you're going to have 4 nodules, and it's going to be on the posterior portion of the thyroid. Some people have less than that, and some people have more. Some people have 2, some people have 6. So it can vary from person to person. But on average, it's going to be 4 little tiny bumps, and those are going to sit on the posterior side of the thyroid gland. The cells that are involved that secrete PTH, those are going to be chief cells or parafollicular cells. And this is all dealing with calcium balance. So what does PTH do? What's the antagonist of PTH? What's the thing that operates in opposition to PTH? Calcitonin. Calcitonin is going to be the major thing that operates in opposition to PTH. Calcitonin maintains the tone of calcium. It reduces calcium levels floating in the blood. PTH does the opposite. The PTH increases calcium levels. So it's going to stimulate what type of cells in the bones? Osteoclasts. Good. So PTH stimulates osteoclasts to crush bone, to release calcium, to elevate the levels of calcium in the body. So if you have low calcium, parathyroid hormone releases PTH, then you get increased calcium absorption at the GI, and you get calcium resorption at the levels of the bone. And then that's going to allow for release of free calcium in the body. As I mentioned, you sometimes see variation in the number of parathyroid glands. Sometimes people have 2 to 6. But the big goal is to increase calcium in response to hypocalcemia. It's also going to work in concert with vitamin D. Right? Vitamin D helps to release, to actually increase absorption of calcium. Right? It's going to be the increased absorption of calcium as well in the GI as well as in the kidneys. Osteoclast activation, and it is the opposite of calcitonin. So it's a calcitonin antagonist. And then here's another chart that basically shows everything that's going on. So if you're hypocalcemic, PTH gets released, you increase your calcium levels afterwards. If you're hypercalcemic, calcitonin gets released from the thyroid gland, right? So the thyroid gland is involved in T3 and T4 as well as with calcitonin. All right, what does PTH do? So we already talked about osteoclasts. So you're going to get osteoclast activation. So you're going to see rank ligand expression to activate the rank receptor on the osteoclast to increase bone resorption. You're going to inhibit osteoblasts. You're also going to get more calcium absorbed at the kidney. And you're going to also see calcitriol, which allows for further absorption of calcium at the level of the GI tract. All right. Now, if you have a disorder of the parathyroid hormone, you can get hyperparathyroidism. An example would be primary hyperparathyroidism. That could be due to a cancer. The most common type is going to be secondary to a parathyroid adenoma. You get way too much PTH, you get way too much calcium, and then you can start rapping your favorite poem, which is the stones, groans, bones, moans, psychiatric overtones, thrones, all that stuff. What's going to happen with the EKG? If you have too much calcium, remember that you get shortened ST segment. Right? If you have too little calcium, you get prolonged, right? Prolongation of that segment. Shortened ST segment on EKG with hypercalcemia. Secondary hyperparathyroidism, that's going to be at the level of the, it could be involving the kidneys, right? So if you have kidney disease, you're not going to get activated forms of vitamin D. So vitamin D is going to involve some multi-step process, right? You have conversion of vitamin D at your skin, and then eventually vitamin D gets activated to its active form in the kidneys. If a person has renal failure, they're not going to be producing vitamin D adequately. And with inadequate levels of vitamin D, eventually you're going to get reduced absorption of calcium at the level of the GI tract. So what's going to happen? You're going to get hypocalcemia. Secondary to hypocalcemia, you're going to see an increase in parathyroid hormone at the level of the parathyroid gland. So this is why it's considered secondary hyperparathyroidism. It's first taking place at the level of the kidneys. We have renal failure, reduced levels of vitamin D, reduced calcium levels, and then you're going to increase the amount of parathyroid hormone produced as a consequence. There's other things that can cause secondary hyperparathyroidism. For instance, if you have just dietary deficiency of vitamin D, that can happen with people who, first of all, don't eat proper foods that contain vitamin D. Also, if they're not exposed to sunlight adequately, folks who live in higher latitudes, in more like northern or super southern latitudes, then they're going to not get enough sunlight. Folks like myself who try to avoid the sun as much as possible because I'm extremely prone to getting pretty bad sunburns, I tend to run a little low on vitamin D. And so supplementation is really important for individuals such as myself or anybody who doesn't get enough sunlight exposure. And then there's also conditions like GI malabsorption. Think about someone who has maybe like celiac disease and they're not going to be able to get enough vitamin D absorbed through their diet. So let's talk about hypoparathyroidism. Now, with hypoparathyroidism, generally speaking, this is going to happen to a person who has had some form of thyroid surgery. So we talked about thyroid ablation. If you were to take radioactive iodine so that you could just destroy the thyroid gland if you have, for example, a cancer that's causing hyperthyroidism. But if you were to do surgery to remove the thyroid gland, because the parathyroid glands are really tiny and they're going to be attached to the posterior aspect of the thyroid gland, then surgery is one of the major factors that contributes to hypoparathyroidism if you're removing the thyroid gland. So you get reduced parathyroid hormone, and as a consequence, you get reduced calcium levels. So you get hypocalcemia. Now remember, with hypocalcemia, it looks like pseudo-hypernatremia. It's almost like you have too much sodium, right? And so you're going to get hyperreflexia. You're going to get muscle spasms or tetany. You're going to get the chopstick sign and the trousseau sign. Remember what the chopstick sign was when we talked about electrolyte imbalances? That's when you tap on the patient's cheek. And when you do so, it's going to force them to grimace. They're going to grimace. Their eyes are going to squint. That's going to be the chopstick sign. And then the trousseau sign is where you place a sphygmomanometer, blood pressure cuff on the patient's arm, pump it up, and you're going to elicit a very unique, how would you say, flexion of all of the fingers in the hands. So it kind of looks like the Italian, delicioso, like, what the Italians do when food tastes really good, right? That's what it's going to look like when you do the trousseau sign. And then with the EKG, you're going to get long QT interval. Remember, with hypocalcemia, you're not going to get enough calcium in the heart to allow for a proper contraction, and so it's going to reflect on the EKG as a long QT interval. So if you're following me on the charts here, you can see a couple things here: primary hyperparathyroidism, secondary hyperparathyroidism, and primary hypoparathyroidism. These are extremely high yield concepts for you to understand. So with primary hyperparathyroidism, what's the level of PTH? Obviously, part of the condition, hyperparathyroid, is going to go up. What's going to happen to calcium levels? Remember that PTH is going to be an important hormone to increase calcium levels. So you're going to stimulate your osteoclast to crush the bone down, break down the bone, demineralize, so you release all that calcium to the bloodstream. So with hyperparathyroidism, you get increased PTH, and you become hypercalcemic as a consequence. Now, what happens when you have something like chronic kidney disease, renal failure, and you have a vitamin D deficiency? Your calcium levels are obviously going to be down. They're going to be low. What's going to happen to parathyroid hormone as a consequence? It's going to try to off-balance the hypocalcemia. So it's going to be elevated so that you can try to increase calcium levels. So that's going to be secondary hyperparathyroidism. Not directly at the level of the parathyroid gland, but it's due to another issue. And in this case, chronic kidney disease. What about primary hypoparathyroidism? Obviously, PTH is going to be low. What's going to happen to calcium levels as a consequence? Also, calcium levels are going to be low. So you're going to see hypocalcemia as a consequence. All right, so now let's move on from the thyroid and the parathyroid gland and move on to the adrenal glands. Now, with the adrenal glands, they're going to, in humans, sit superior to the kidneys. And let's do a little bit of a review from what you guys learned in anatomy and physiology with adrenal gland anatomy. And so with the adrenals, you're going to have two major sections. You're going to have the adrenal medulla and you're going to have the adrenal cortex. The adrenal cortex sits outside of the adrenal medulla. Within the adrenal cortex, you're going to have three separate layers, and the mnemonic I like to use is GFR. It's similar to glomerular filtration rate, like what you'd see when you're measuring the kidney's urine output. So GFR, going from superficial to deep, you're going to see the zona glomerulosa, zona fasciculata, and zona reticularis. What do these three different layers do? Now, here's a way that my friends and I in medical school remembered what the three different layers would be responsible for in the adrenal cortex. So we thought about the adrenal cortex as going from younger layers to the older layers. Younger layers being on the inside, with the older layers being on the outside. So you can kind of think about that in terms of like the brain, for example. The cerebral cortex is, more pronounced in more advanced organisms such as ourselves, organisms that have, evolved a little bit throughout evolutionary history to have more advanced capabilities in terms of cognition. But in the adrenal cortex, you kind of think about it the same way, right? So you're going from younger layers to the older layers. What's going on with the younger layer? So younger people are going to be thinking more about sex. Right? They're going to be a little bit more preoccupied with notions of sex. And so what does the zona reticularis do? Zona reticularis is going to be responsible for production of your androgens or sex hormones. Then you move one layer beyond that, the zona fasciculata. As you get a little bit older in your life, now you're going to be a little bit more stressed out. You're going to be thinking more about things that stress you out, maybe like your work responsibilities, for example. So that's going to be the zona fasciculata, which produces glucocorticoids, cortisol being one of the major stress hormones. Why is it called a glucocorticoid? Because glucocorticoids not only deal with stress response, but they also increase the amounts of glucose available within your bloodstream. That's why it's called a glucocorticoid. What happens when you move beyond that in the adrenal cortex? You get into the zona glomerulosa, and this is the older layer. And what do old people think about a lot? They think about salt in their diet, right? They're worried about hypertension, high blood pressure, and so they're worried about salt. What does the zona glomerulosa do? It deals with mineral corticoids, aldosterone release, mineral corticoids, dealing with sodium-potassium balance, right? And if you have release of aldosterone, you're going to bring on more sodium, you're going to excrete potassium, you're going to become hypernatremic, and you're going to become hypokalemic as a consequence of your mineral corticoid release, aldosterone release. Then when you get down to the very middle layer of the adrenal cortex, it's the adrenal medulla. And what does the adrenal medulla do? It's going to be responsible for release of catecholamines. So epinephrine, norepinephrine. This is your sympathetic nervous system fight and flight response, right? When you're in a fight and flight scenario, running away from a tiger, or maybe running away from someone you don't really like very much, then you're going to get the release of epinephrine and norepinephrine as a consequence. So I have several slides here that talk about the different layers of the adrenal glands, the adrenal cortex, the adrenal medulla, etc. Review those so that you have a solid foundation and understanding of what the adrenals do. So now let's talk about the HPO axis and how that involves the adrenal glands. So HPO axis for the adrenal glands, when you're talking about, for example, cortisol release, the hypothalamus is going to release CRH, or corticotropin releasing hormone. Then, when that gets down to the anterior pituitary is going to release ACTH, or adrenocorticotropin hormone. Now, something else that's a precursor for ACTH is going to be POMC. Now, what does POMC stand for? It's pro-opiomelanocortin, and I'm not going to use that term anymore for the duration of this lecture. I'm only going to refer to that as POMC. So what does POMC do? POMC is a gene. It's an important part of the HPO or HPA axis, and it's going to be a prohormone for adrenocorticotropic hormone, or ACTH. So POMC is a precursor for ACTH. So it's really important in moderating the adrenocortical response to stress. So when the anterior pituitary releases POMC and ACTH, that's eventually going to make its way down to the adrenal glands. And at the adrenal glands, that's where you get the release of cortisol. So CRH from the hypothalamus, POMC and ACTH from the anterior pituitary, and at the adrenal glands, you're going to get cortisol release. What else does POMC do? POMC is also a precursor to MSH, which is melanocyte stimulating hormone. And when melanocytes are stimulated, those are going to release melanin, and that's going to cause darkening of the skin. And we'll talk about why that's important when we start talking about Addison's disease in a second. Another thing that you could see too with the HPO axis with the cortisol pathway, you can also see androgens and aldosterone being involved in this too. So we'll talk about how androgens and aldosterone come into play, especially when we discuss Cushing's disease. So to summarize, the zona glomerulosa, that's where you have mineralocorticoids. That's where you have aldosterone getting released. That's one of the major mineralocorticoids involved. That's going to allow for reabsorption of sodium, and it's going to excrete potassium in exchange. So if you have a lot of aldosterone, you're going to be hypernatremic and you're going to be hypokalemic as a consequence. What else does aldosterone do? It's going to also make you more sensitive to the taste of salt. So you're going to want to consume more salt as a consequence. Now, what else does aldosterone do? Here's one thing I really want you guys to keep in mind when it comes to potassium. I want you to associate potassium with hydrogen ions as well. Now, when you have the exchange of sodium and potassium, you're also going to have the exchange of sodium and hydrogen ions too. So if you have lots of aldosterone released, you're going to increase sodium, but you're going to lose potassium. You're also going to lose hydrogen ions as well. When you lose hydrogen ions in the kidneys, in your urine, you're going to become alkalotic. So if you have lots of aldosterone, you're losing potassium, you become hypokalemic. You're also losing hydrogen ions, and because of that, you're going to become alkalotic. Your pH levels are going to increase as a consequence. So aldosterone increases sodium. Aldosterone decreases potassium levels because of potassium excretion. Aldosterone decreases hydrogen ions because of excretion, and it's going to increase your pH, causing alkalosis. Now let's discuss two different diseases that are going to be dealing with aldosterone. The two diseases are going to be Addison's disease and Conn's disease. That's C-O-N-N apostrophe S. Conn's disease and Addison's disease operate in opposite from one another. With Addison's disease, you have reduced aldosterone release. Because of that, you're going to have low sodium levels because you're going to be wasting sodium in the urine. You're going to become hypotensive because you're going to reduce your blood volume because remember, the renin-angiotensin-aldosterone system, when that comes into play, the whole purpose is to increase your blood pressure, increase your blood volume. Now, if you don't have enough sodium, then you're going to excrete more water. And then you're going to become hypovolemic, you're going to become hypotensive. Now remember, water follows solutes. So if you're excreting sodium, you're also going to be losing water as a consequence. You're going to become hyperkalemic, right? Because you're not exchanging the sodium for potassium. And so with Addison's disease, you have a lot of potassium in your serum. Now think about potassium in association with hydrogen ions. If you're increasing hydrogen ions, you're going to become acidotic. So this would result in metabolic acidosis. Now with Conn's disease, it is completely the opposite. You have way too much aldosterone being released. Too much aldosterone means you're bringing on too much sodium, so you're going to become hypernatremic. You're going to become hypertensive. Your blood pressure goes up, your blood volume goes up, right? Water follows solutes, especially sodium, and so you're going to see blood pressure increase. You're going to lose potassium because you're exchanging sodium for potassium. So you're going to waste potassium, you're going to become hypokalemic. Think about what that's going to do to your EKG levels. Your EKG, you're going to see T-wave blunting, right? The T waves are going to be short, and you might see a U wave as a consequence with hypokalemia. Versus Addison's disease, you're going to see hyperkalemia and you're going to see T-wave spiking. And then with Conn's disease, Conn syndrome, you're going to see metabolic alkalosis because you're going to be dispensing with a lot of your hydrogen ions. You're going to waste it away, and then as a consequence, your pH levels are going to rise. You're going to become alkalotic. Now, if you follow this high yield chart that I put together here, you got increased aldosterone with Conn syndrome. What happens with sodium? Increased aldosterone, sodium levels go up. What about potassium? Potassium goes down. Blood pressure and blood volume is going to, of course, go up because water follows solutes. Hydrogen, it's going to be the same as potassium, so it's going to go down. pH levels are going to go up, so that's going to result in alkalosis, metabolic alkalosis. What about renin levels? Now let's think about what renin does. Because remember, renin-angiotensin-aldosterone system, or the RAS system. What's the purpose of the RAS system? The RAS system is there to increase blood volume, to increase blood pressure. The RAS system comes into play as soon as you start seeing hypotension, hypovolemia, as well as hyponatremia. And so when the RAS system comes into play, it's going to help to increase your blood pressure. With Conn syndrome, your blood pressure and blood volume is already extremely high. What's going to happen to renin? It's by consequence going to go down because you don't need renin to increase the blood pressure any further. The blood pressure is already high enough. Blood volume is already high enough. Now, let's switch over to Addison's disease. Addison's disease, you have decreased aldosterone. Decreased aldosterone, decreased sodium. Increased potassium in your serum. Blood volume and blood pressure is going to tank. It's going to go down. You're going to become hypotensive. Potassium is going to be similar to hydrogen ions. Hydrogen ions are going to go up in Addison's disease. This person is going to be experiencing metabolic acidosis. They're going to have a low pH level. What's going to happen to renin levels? Now remember, renin is important for increasing blood volume and blood pressure. Addison's disease has low blood volume and low blood pressure. Renin is going to go up as a consequence. So make sure you're familiar with all the different changes in ions and even the changes in renin levels when you have increased or decreased sodium and potassium levels. So Conn syndrome, primary hyperaldosteronism. Why do you get this? Usually it's going to be due to a cancer. It's going to be an adrenal adenoma. When you hear adenoma, that's going to be any sort of tumor that affects a gland, a hormone secreting gland. And so with Conn syndrome, you're going to get aldosterone being affected by this. So it's an adrenal adenoma. So it's going to cause hyperaldosteronism, which means you get increased sodium and hypertension. You're going to get decreased potassium because hydrogen and potassium is going to be similar in these types of conditions. Your hydrogen ions go down. You're going to get alkalosis as a consequence. And then you're going to get decreased renin, right? Because you're hypertensive, your blood volume is high, your renin levels are going to be down. How can you test for this? You can just take a look at a person's CT scan and see if they have any sort of tumors on their adrenal glands. All right, so I have a case presentation here that you're not going to be able to see because I covered it up, but the case presentation is about a very, very famous man who I have a photograph of him. I actually have another photograph of him in this lecture series, but it's John F. Kennedy, JFK. When he was 30 years old, and remember, he's one of the youngest presidents, right? You can run for president at 35 years of age in the United States, and I forget how old he was when he obtained the presidency, but he was the youngest man to become president in the United States. But when he was 30 years old, he was actually being tested for a particular condition that affects his adrenal glands. So 30-year-old patient, no significant past medical history, presents to clinic in 1947 with fatigue, nausea, darkening of the skin, and dizziness upon standing. So let's think about some of the things going on here. So fatigue, dizziness upon standing. Why would somebody get dizzy when they stand up? That's considered orthostatic hypotension. The moment you stand up, blood is going to pool down to your feet and it's going to escape from your brain, basically. And that's going to cause dizziness, and you can basically pass out from that too. The bronzing of the skin. Remember, a few slides back, we talked about COMT, right? So let's talk about what's going on with the bronzing of the skin. Let me go back to that one slide that we were talking about here. Where's that? All right, not COMT, POMC. POMC. POMC is going to be a hormone that's released that's going to allow for the production of ACTH, but it's also going to allow for the production of melanocyte-stimulating hormone, MSH. Now, if you have POMC being involved in a condition like Addison's disease, I just gave it away. This patient has Addison's disease. So what's happening as a consequence? They're going to have elevated levels of ACTH they're going to have elevated levels of POMC. ACTH and POMC can increase melanocyte activation. So ACTH in and of itself can also activate melanocytes, but then also you have MSH, which is your melanocyte stimulating hormone, can also, of course, affect your melanocytes. And so with JFK, what was going on with him? He had Addison's disease. So he was diagnosed when he was 30 years old. Low blood pressure, he had darkening of the skin. Kind of an interesting story with JFK is that when he was running for president, Addison's disease might have actually helped him garner more affinity from the American public. He looked, first of all, he was young, good-looking guy, and he was also very tan, and he had bronzing of the skin. So it looked like he kind of maybe just came back from vacation. So he looked, super, super smooth. He was very charismatic during the debates against Richard Nixon at the time. And Richard Nixon, he looked kind of pale. He looked kind of cranky. He was kind of like a fuddy-duddy. And, folks weren't really persuaded much by Richard Nixon at that time. Of course, later on, Richard Nixon did become president. But during this particular cycle of the presidential election, John F. Kennedy definitely swayed the American public to vote for him instead. So he looked very fresh and young. But part of that was because he had darkening of the skin, looked nice and tan due to his Addison's disease. So what's going on with Addison's disease? With Addison's, you're not getting enough aldosterone produced. You're also not going to get enough cortisol produced as well. If you have too little aldosterone and too little cortisol, especially with cortisol, you're going to see CRH being elevated. You're going to see ACTH being elevated, right? Those are your corticotropin releasing hormone and ACTH, adrenocorticotropic hormone, to help increase your cortisol levels. Now, if you have a lot of ACTH floating around, that's going to also stimulate those melanocytes to be able to work. Now, what's going on with Addison's disease? You have too little aldosterone, too little cortisol. With that, you're going to be hypovolemic. You're going to have low blood pressure. That's also going to cause a little bit of weakness. For the skin, with the melanocyte stimulating hormone and just stimulation of melanocytes from ACTH, you're going to get hyperpigmentation. For the GI, you're going to get a little bit of nausea, diarrhea, constipation, etc. There's a chart here that I have that goes through all the different steps of what an adrenal gland dysfunction can cause. So this is with the Addison's adrenal crisis. If you have an Addisonian crisis, this is extremely life-threatening, and it can be brought upon by stress. If you're fighting off an infection, for example, that can throw you into an Addisonian crisis. So let's look at the top level of this chart. First, what's going to happen with cortisol levels? Cortisol is going to be extremely low, right? You're not able to produce enough cortisol. What's going to happen with reduced cortisol? You're going to have low sugar, low glucose, because cortisol, remember, is a glucocorticoid. If you don't release enough glucocorticoids, your glucose levels tank. And so you're going to become extremely hypoglycemic. And the brain, of course, really needs glucose to be able to function. So the brain could potentially go into coma, and that can also result in death. Now look at the bottom side of the chart here. You have aldosterone. Your aldosterone levels with Addison's is going to be very, very low. With low aldosterone, you're not going to get enough sodium reabsorption at the kidneys. You're going to lose sodium. That's going to reduce your blood volume. If your blood volume goes low enough in an Addisonian crisis, that can put you into shock. What happens also if you have too little sodium? That's going to throw you into arrhythmias because your heart and your cardiac myocytes require sodium to allow for the heart cells to contract properly. So you're going to go into a irregular heart beat, so arrhythmias. That can also throw off your blood pressure and push you into a state of shock, and that can also throw you into coma and death. So that's how an Addisonian crisis works. So here's a summary of Addison's disease. Chronic adrenal insufficiency. Why do you get this? It's usually going to be associated with autoimmune destruction of the adrenal cortex. That's going to be the most common cause, is autoimmune. And there's going to be a negative feedback loop because you have too little aldosterone, you have too little cortisol. Your hypothalamus is going to try to correct for that by releasing CRH. Then you're going to see increase in POMC. You're going to see increase in adrenocorticotropin hormone, or ACTH. You're going to increase MSH. That's what's causing the darkening of the skin. And with reduced aldosterone, what else would you see? Renin is going to be elevated, right? Because your blood pressure is low. You have hyponatremia, blood pressure is low. That's going to increase renin. You're also going to see hyperkalemia with low aldosterone, right? Because you're not able to bring in sodium, so you're going to have an excess amount of potassium. What kind of things are you going to see on an EKG with hyperkalemia? You're going to see T-wave spikes, right? You're going to see a very large T-wave with hyperkalemia. You're also going to see acidosis, right? Because remember, potassium and hydrogen ions, you have sodium potassium antiports, and you have sodium hydrogen antiports. You're going to see metabolic acidosis as a consequence. And then you're going to see darkening of the skin and hypoglycemia as a consequence because of the reduced cortisol. If you have decreased adrenal function, that's going to be Addison's disease. Low glucocorticoids, also low mineral corticoids. High ACTH, high MSH. What else can you see with a patient with these types of conditions? You might see infection causing Waterhouse-Friderichsen syndrome, or WFS. Now, what's going on with Waterhouse-Friderichsen syndrome? Generally speaking, this is going to be adrenal gland failure secondary to meningitis. If you have bacterial meningitis, the main cause is going to be Streptococcus pneumoniae. That's the major cause of bacterial meningitis. Another common cause of meningitis is going to be meningococcal meningitis, and that's going to be Neisseria meningitidis. It almost looks like regular Streptococcus meningitis, but one of the major differences is that you see purpura on the skin. So you'll see these purpural type lesions. You see like microhemorrhaging too, with petechia and things like that. And so you can also have that organism, Neisseria meningitidis, affecting the adrenals. And if you have adrenal insufficiency from an infection, that's Waterhouse-Friderichsen syndrome. So let's summarize Addison's real quick here. So signs and symptoms: low aldosterone, low sodium, hypotension, fatigue, high potassium, weakness, nausea and vomiting. You get metabolic acidosis because with high potassium, you also see high hydrogen ions. Low cortisol, low glucose, hypoglycemia. You see elevated MSH. Then you see melanocytes are going to be stimulated, and you're going to see hyperpigmentation. Weight loss, weakness, thin. You can see that as well as a consequence. How do you test for this? You can obviously test for ACTH levels. You can test for sodium, potassium, glucose. You can check their cortisol, aldosterone, and then you can do a CT scan or an MRI to see if they have any sort of lesions at the site of the adrenal cortex. So, cortisol. Now let's focus more on just cortisol, because Addison's disease involves cortisol and aldosterone, but there's some conditions that mostly affect cortisol. Why is cortisol important? It's one of the major stress hormones. First of all, cortisol gets released at different times of the day, especially in the morning when you're waking up. Cortisol is important to provide you with like motivation, right? So you can get up and go about your day. It also helps to increase the amount of glucose in your blood. So it also allows for gluconeogenesis at the level of the liver too. So cortisol can be pretty important, but only in small doses. You don't want to have too much cortisol, because if you have too much cortisol, that can be pretty bad as well. You're going to get into like metabolic syndrome, too much glucose floating around in your bloodstream. Where is cortisol made? It's going to be that zona fasciculata, that middle layer of the adrenal cortex. And it's released in response to ACTH from the anterior pituitary gland, adrenocorticotropin hormone. What's the function of cortisol? So we talked about how it allows for increased glucose levels, so you can get gluconeogenesis at the level of the liver. It also helps to degrade proteins, so you can actually free amino acids when you're breaking down proteins. You also get lipolysis as a consequence, so it breaks down lipids, so it increases fatty acids. It can also affect your bone density because it can stimulate osteoclasts to increase bone resorption. And think about cortisol and like drugs like prednisone and other anti-inflammatory drugs. Anti-inflammatory drugs like prednisone reduce inflammatory process, and they are going to mimic the effects of cortisol. If you have lots of cortisol floating around, you're going to be immunosuppressed. You're going to be immunocompromised. So that means you're going to have a high risk for infection as a consequence. And you're going to get slow wound healing. Now, what happens if you have way too much cortisol or drugs that look like cortisol floating around your body? So if you take prednisone for too long, or like glucocorticoids to reduce inflammation, eventually you're going to develop Cushing's disease. Cushing's. We'll talk about the difference between Cushing's disease and Cushing's syndrome. But Cushing's is going to be one of the effects of too much cortisol. So you get lots of glucose. If you're hyperglycemic, remember your 3 P's of hyperglycemia: polyuria, polydipsia, polyphagia. You're going to be urinating a lot, you're going to be drinking a lot of fluids, and you're also going to want to eat a lot of food. Those are your 3 P's of hyperglycemia. You're also going to get lots of fatty acids being released in your body, right? Because you're going to be breaking down lipids. So you get free fatty acids floating around. That's going to cause truncal obesity in these patients, and it's also going to affect their face. They're going to get moon face. Right at their back of the neck, they're going to get buffalo hump, so you get fat accumulation in the back, and in their belly, because of the enlargement of the belly due to truncal obesity, you're going to see purple striae, which are stretch marks. You're also going to see amino acids getting converted into glucose, right? Because amino acids can break down and turn into glucose. So you're going to see reduced proteins. With the reduced proteins, you're going to get thinning of your appendages. Your arms and your legs are going to be a little bit thinner because you're breaking down proteins. So you have a truncal obesity, so larger abdomen. You're going to have buffalo hump. You're going to have moon face, but then you're going to have wasting of your arms and legs. Another thing that you might see too is poor bone formation and reabsorption and osteoporosis as a consequence. You're also going to see kidney stones, because if you're getting a lot of osteoclasts being activated to break down bone, all that free calcium can cause your favorite poem of bones, stones, groans, psychiatric overtones, thrones, etc. All the things that you will see with hypercalcemia. So Cushing's disease versus Cushing's syndrome. Both of these are going to increase cortisol levels, but they're going to be a little bit different than each other. Cushing's syndrome is going to be at the level of the adrenals. Cushing's disease is going to be at the level of the pituitary gland. Okay, so you're going to see a major difference between these two conditions. Cushing's syndrome, because it's at the level of the adrenals, it's an adrenal adenoma, you're going to get negative feedback as a consequence. So at the level of the adrenals, you're getting way too much cortisol being produced. With lots of cortisol, guess what? You're going to have negative feedback. So at the hypothalamus, CRH is going to be reduced. At the pituitary, low POMC and low ACTH. You're also going to get low melanocyte stimulating hormone, or MSH. So you're not going to see skin darkening with these patients. Cushing's disease, on the other hand, that's at the level of the pituitary gland. So that is a pituitary adenoma producing way too much ACTH. What are you going to see? Lots of POMC, lots of ACTH, lots of MSH as well. Remember, ACTH can actually also stimulate melanocytes too. So with high ACTH, you're going to get a lot of cortisol. You're going to get more MSH. MSH is going to cause darkening of the skin. Androgens are going to cause hirsutism and amenorrhea. For women with hirsutism, you're going to see hair growing in places that it doesn't belong, like around the lips, around the sideburn area. And then for menses, you're going to see that's disrupting the normal menstrual cycle. So you're going to see amenorrhea as a consequence. Aldosterone is going to be really high. So they're going to have lots of sodium, little potassium. They're going to be hypertensive, and they're also going to be alkalotic, because remember, with little potassium, you also think that hydrogen ions are going to be wasted too. So you're going to have low hydrogen ions causing metabolic alkalosis. And then, of course, cortisol is going to be really high. So you have elevated cortisol in both of these conditions, but the major difference is going to be the location of the disease. The location for Cushing's syndrome, adrenal glands. Location for Cushing's disease, pituitary glands. So if the pituitary is affected, you're going to see way more things downstream as a consequence, right? So Cushing's disease is going to be a little bit more severe than Cushing's syndrome. So let's focus on Cushing's disease. Cushing's disease, you have a pituitary adenoma, increased POMC, increased ACTH, increased cortisol, increased MSH, increased aldosterone, increased androgens. For ladies, you're going to see a lot of facial hair, thickening of the facial hair. So that's hirsutism. You can also see acne as well. In terms of the menstrual cycle, amenorrhea. It could be irregular or absent. For guys, you're going to see ED, erectile dysfunction, right? Because you're going to see some changes in androgens. What about aldosterone levels? Aldosterone levels are going to be really high with Cushing's disease. So you're going to see hypernatremia. You're going to see increased blood volume and blood pressure, so hypertension and headaches. You're going to see low potassium, so hypokalemia, metabolic alkalosis because of low hydrogen ions, and you're going to see low renin secretion because your blood pressure and blood volume is already really high, so you don't need any more renin to come into play. You're going to see skin hyperpigmentation because of the melanocytes. You're also going to see darkening of those stretch marks. So the striae are going to be purple in color, so purple striae. You can also see mood changes too. So like depression is common with this, irritability, anxiety. Cortisol in general, like if a person takes prednisone, anyone who's taken prednisone can tell you that it's going to cause a little bit of like anxiety. They feel a little jittery, like they're crawling out of their skin. So you can see mood changes with Cushing's disease as well. What's the major cause of Cushing's disease? Remember, we talked about the pituitary. It's going to be a pituitary adenoma. That's going to be the major cause of Cushing's disease, about 70% of cases. What's the cause of Cushing's syndrome? Adrenal adenoma. That's going to be the major cause at the level of the adrenal glands. What can you do to test for this in the lab? You can look for their glucose levels. If they're hyperglycemic, if they have elevated lipids, hyperlipidemia, if they have lots of aldosterone, hypernatremia, high blood pressure, if their potassium levels are low, and they're alkalotic, then you can diagnose this person with Cushing's disease. You can also check their urine for levels of cortisol. So cortisol levels are going to be elevated within the urine with Cushing's disease. ACTH. Here's one way that you can differentiate between the pituitary and the adrenals. If the adrenals are affected, what's going to happen to ACTH? ACTH from the pituitary. If the adrenals are releasing way too much cortisol, then the ACTH levels from the pituitary are going to be low, right? Because the pituitary is trying to put the brakes on. It's trying to stop cortisol from being released. It's not going to work, but it's doing its best to try to reduce cortisol levels. But because Cushing's disease affects the pituitary gland, then you're going to see ACTH levels elevated because the pituitary is releasing way too much ACTH. You can also do a CT scan to see which areas are going to be affected by this disease. All right, so I have a chart here that gives an overview of Addison's versus Cushing's disease. So let's go through Addison's disease first. Addison's disease, what's happening? It's mostly going to be involving aldosterone, okay? So aldosterone levels are going to be reduced with Addison's disease. What's happening with CRH, cortisol releasing hormone? Addison's disease also affects cortisol. So you have aldosterone and cortisol being low. CRH is going to be elevated as a consequence. What about POMC, ACTH, MSH? Remember, Addison's disease, you got bronzing of the skin, right? So MSH is obviously going to be elevated. POMC is also going to be elevated. So POMC, ACTH, and MSH are going to be elevated. Cortisol and aldosterone are both going to be low. Okay? So low cortisol, low aldosterone results in high CRH, high POMC, high ACTH, and MSH. What about Cushing's syndrome? Remember, Cushing's syndrome is going to be at the level of the adrenals. So what's happening with CRH? You're going to have high cortisol levels with Cushing's syndrome. So CRH is going to be low. What about POMC and ACTH and MSH? Also are going to be low, right? Because this is at the level of the adrenals. The adrenals are hypersecreting cortisol. Cortisol levels are going to be elevated. What about aldosterone levels? Aldosterone is not affected by Cushing's syndrome. It's only cortisol. Now, on the other hand, Cushing's disease, again, affecting cortisol levels. What's the CRH going to be with Cushing's disease? Remember, Cushing's disease at the level of the pituitary gland. Where is CRH released from? The hypothalamus, right? And so if the pituitary gland is hypersecreting, the hypothalamus is going to try to put the brakes on. So it's going to have reduced CRH. POMC, ACTH, MSH are all going to be elevated, right? Because this is at the level of the pituitary gland with Cushing's disease. Cortisol is going to be obviously high. Now, what about aldosterone? This is going to also affect aldosterone release. So you're going to have hyperaldosterone release and hypernatremia as a consequence. Now, I have another overview slide here. I guess I can go through all this. The first one is Cushing's disease for A. So with Cushing's disease, you're going to see high cortisol, high aldosterone, high POMC, ACTH, MSH. However, at the hypothalamus, CRH is going to be low. What about B? That's going to be Conn's syndrome. So look at Conn's syndrome. You're going to have lots of aldosterone being released. So aldosterone is really high. CRH is normal. POMC, ACTH, MSH is normal. Cortisol is also normal. What about C? Let's see here. You got CRH is high, POMC, ACTH, MSH is all high. Aldosterone is low and cortisol is low. That is Addison's disease. That's JFK, right? So he's got bronzing of the skin. He's got low blood pressure, low sodium, etc. What about D? Your CRH is low, ACTH is low, aldosterone is normal. Cortisol is really high, though. That is going to be at the level of the adrenals. That is Cushing's syndrome. Now, I have another chart here that is extremely high yield, and it goes through Conn's syndrome, Addison's, Cushing's, and Cushing's syndrome. Now, let's start with Conn's syndrome. Everything that I have highlighted in purple, that's going to be the first thing to either go up or go down. So let's go through it. What is going on with Conn's syndrome? Aldosterone levels are what? High or low? Conn's syndrome is opposite of Addison. So Conn's syndrome, aldosterone is high. What about CRH? Is that going to be affected? CRH is not going to be affected when aldosterone is high. Remember, aldosterone is only dealing with sodium and potassium. What about POMC, ACTH, MSH? Is that going to be high or low? It's actually going to be normal, right? Because aldosterone, again, is dealing with just mineral corticoids. Now, what about cortisol levels? It's going to be normal. What about your androgens? That's going to be normal. Now, what about renin? Renin is going to be changed, right? Because with aldosterone, you're increasing blood pressure and blood volume. Is renin going to go up or down? Remember, renin is important for increasing blood volume. If your blood volume and blood pressure is already high, then renin is going to be low. Now let's switch down to Addison's disease. We're going to start at aldosterone and cortisol. Addison's disease affects both aldosterone and cortisol levels by reducing them, right? So you have reduced aldosterone, reduced cortisol. Because cortisol is low, what about CRH from the hypothalamus? It's trying to increase cortisol, right? So it's going to be up. POMC and ACTH and MSH, what's going on with that? Those are all going to be up as well, right? That's why you get the bronzing of the skin with MSH and whatnot. Androgens are going to be normal, but now renin, what's going on with renin? Your blood pressure is down, right? So renin is going to try to counteract that, so it's going to be elevated. All right, now let's switch down to Cushing's disease. Cushing's disease is going to be at the level of the hypothalamus. So what's going on with ACTH, MSH, POMC? Those are all going to be elevated. What about CRH at the hypothalamus? CRH is going to be down because it's trying to put the brakes on, right? Aldosterone is going to be up. Cortisol is going to be up. Androgens are going to be up. What about renin? You have high blood pressure now. Renin is going to be down. Now the last one, Cushing's syndrome, at the level of the adrenal cortex. Cortisol. Adrenal cortex, cortisol is going to be up. CRH from the hypothalamus, up or down? Going to be down. POMC, ACTH, MSH is going to be down. Aldosterone, is it affected at all by cortisol? No, it's not. Aldosterone levels are going to be normal. Androgens are going to be normal. What about renin? Renin is also going to be normal too, because that's going to be affecting, there's going to be no effect on aldosterone, there's going to be no effect on blood pressure. All right, so I have a practice question here, and let's just go through it real quick. So you have a patient, their labs, you look at their CBC, complete blood count is normal. You look at their ABGs, that's arterial blood gas. They are alkalotic, their pH is elevated at 7.49, so alkalosis. Bicarb is also elevated at 35, and their CO2 levels are 40, which is normal. Sodium levels, 146, so that's slightly elevated, just by a little bit, because upper range is 145, so 146 is slightly up. Serum potassium is low, so they're hypokalemic, 3.1. Glucose levels is really high for fasting, 162. They also have elevated cortisol and elevated ACTH. What's going on with this patient? Well, look at the cortisol levels. You know that this is Cushing's now. So Cushing's cortisol, if it's elevated, it could either be Cushing's syndrome or Cushing's disease. If it's Cushing's syndrome, you would only really see elevation of cortisol. Everything else would be pretty much normal, except for their glucose. This patient has Cushing's disease because it's involving ACTH as well. So everything is going to be pretty much elevated with Cushing's disease. All right, so now for this next part, we're still going to talk a little bit about the adrenal glands, but we're going to move away now from Cushing's, Addison's, and Conn's syndrome. But we're going to talk about some other diseases that can affect the adrenal glands, but it involves enzymes. There are the three major enzymes that we're going to be working with here. 17-hydroxylase, 21-hydroxylase, as well as 11-hydroxylase. Now, the chart that I have on the slides here, this is a very well-known biochemical chart that talks about how cholesterol can be turned into either aldosterone, cortisol, testosterone, or estriol, which can form estrogens. Now, estriol, estradiol, estrone, which are all your estrogens. Now, a lot of these intermediary steps are admittedly extremely difficult to pronounce, so I'm not going to make you have to memorize each of those, but I want you to understand the basic mechanisms of each of these enzymes and what they effectively do. So let's look at the very top left where we start with cholesterol. Cholesterol is eventually going to be turned into pregnenolone. Now, pregnenolone is going to be the precursor for either progesterone or 17-hydroxypregnenolone. Okay? Now, the thing that converts pregnenolone into 17-hydroxypregnenolone is going to be 17-hydroxylase. So that's going to be one of the first enzymes that we're going to talk about. So, if you don't have 17-hydroxylase, and if you have a 17-hydroxylase deficiency, what are you going to see in terms of aldosterone levels? Are you going to be able to form aldosterone? So if you look at the chart, follow cholesterol, pregnenolone, progesterone, then you have 21-hydroxylase and 11-hydroxylase, which helps to convert progesterone into eventually aldosterone. So with 17-hydroxylase deficiency, you're actually still able to produce aldosterone. All you need is your 21-hydroxylase and 11-hydroxylase to be able to produce aldosterone. So your aldosterone levels are actually going to be elevated with a 17-hydroxylase deficiency. However, everything else is going to be pretty low because if you don't have 17-hydroxylase, you're not going to be able to produce cortisol. You're not going to be able to produce testosterone. You're not going to be able to produce your estrogens as well. Now, what about 21 and 11-hydroxylase? Let's look at 21-hydroxylase first because it's the first one that comes up in these flowcharts. 21-hydroxylase is important to convert progesterone into 11-deoxycorticosterone, which eventually turns into aldosterone. And then it's also important for converting 17-hydroxyprogesterone into deoxycortisol, which eventually turns into cortisol. Now, if you have a 21-hydroxylase deficiency, you're not going to be able to produce aldosterone or cortisol. And instead, you're going to be using those precursors to produce testosterone, androgens, as well as your estrogens. So in other words, you're going to have reduced aldosterone, reduced cortisol, and you're going to have increased androgens and increased estrogens. That happens with both 11 and 21 hydroxylase deficiencies, right? Because 11 and 21 hydroxylase are going to be important for producing aldosterone and cortisol, not for the production of androgens or estrogens. So let's recap that real quick. With a 17-hydroxylase deficiency, you can still produce aldosterone, but you're not going to be able to make the precursors for cortisol, androgens, or estrogens. With 21 or 11-hydroxylase deficiency, you're not going to be able to produce your aldosterone or cortisol, but you're going to be able to still produce androgens and estrogens. But you're going to get those in excess because you're going to have increased amounts of your precursors. So let's go over to this chart that I have on the next slide where it talks about aldosterone, cortisol, androgens, and estrogen levels and how they relate to 11-hydroxylase deficiency, 17-hydroxylase deficiency, or 21-hydroxylase deficiency. So let's start with 11-hydroxylase deficiency. What are your aldosterone levels going to be with 11-hydroxylase deficiency? Aldosterone is going to be reduced, right? Because you can't convert your 11-deoxycorticosterone into corticosterone, which would eventually turn into aldosterone. So your aldosterone levels are low. What about cortisol levels? Are they going to be low? Yes, they're also going to be low. Now, what about androgens and estrogens? Are they going to be low? No, because you're able to still produce androgens and estrogens, but you're going to have lots of those precursors left over. So you're going to have excess amounts of androgens and you have excess amounts of estrogens as well. What about 17-hydroxylase deficiency? This is a little bit different, right? Because it's going to involve a different pathway. Are you still able to produce aldosterone with 17-hydroxylase deficiency? The answer is yes. And in fact, you're going to get lots of aldosterone as a consequence because you have lots of those precursors floating around. What about cortisol? Is cortisol going to be able to be produced? No, because 17-hydroxylase is important to create both 17-hydroxyprogenolone as well as 17-hydroxyprogesterone. And both of those are going to be precursors for cortisol. So cortisol levels are going to be markedly reduced as a consequence. What about androgens? No. Androgens and estrogens are both going to be low because you need 17-hydroxylase as to create those precursors for androgen and estrogen. So with 17-hydroxylase deficiency, you're going to see increased aldosterone levels. Everything else is going to be low. Now, what about 21-hydroxylase deficiency? I'm going to tell you that 21-hydroxylase deficiency is basically the same as 11-hydroxylase deficiency insofar as you're going to have decreased production of aldosterone, decreased cortisol, but your androgens and estrogens are going to be elevated, right? So you're going to have virilization and feminization of individuals affected. So let's talk about these enzymes in terms of congenital adrenal hyperplasia. Now, with congenital adrenal hyperplasia, with reduced cortisol, every single one of these are going to cause low cortisol levels. 11, 17, and 21-hydroxylase deficiency are going to result in low cortisol levels. What's going to happen as a consequence? Your adrenocorticotropin hormone from the pituitary gland is going to be markedly elevated. Because of that elevation in ACTH, you're going to get hypertrophy and enlargement of your adrenal glands. It's very similar to what happens with your thyroid disorders. If you have like TSI, thyroid stimulating immunoglobulin, binding onto the thyroid gland, and Graves' disease, that's going to cause hypertrophy of the thyroid gland. So you're going to get goiter as a consequence. So it's similar to a goiter, right? So this is like the goiter of the adrenals. So you're going to have enlarged adrenal glands, hence the term congenital adrenal hyperplasia. So it's going to be enlarged. 17-hydroxylase deficiency, you have increased aldosterone. Everything else is going to be low. Because of low androgens and low estrogens, the person is going to look like a female. So they're going to have a female phenotype. Even if they are a man, they're going to look like a woman. And you're going to have no maturation. So it's going to look like an immature female. Now, if you remember from your studies in basic biology, and you learned about what differentiates a man from a woman, all humans are going to by default be female. The major thing that differentiates a man from a woman is on the the Y chromosome. You're going to have the SRY gene. The SRY gene is what allows for virilization of a male. Otherwise, if the SRY gene and the Y chromosome wasn't present, then you would by default be a female. That's why if you don't have androgens or estrogens, you're going to also be phenotypically female. And because of no estrogens, this person is also not going to undergo proper maturation. Right? So you're going to have no maturation during puberty. On the other hand, 21-hydroxylase deficiency, you're going to see low aldosterone, low cortisol, but on the other hand, you're going to have increased androgens and estrogens as a consequence. And so you're going to see female pseudo-hermaphroditism. So this person is going to look ambiguous in terms of their genitalia. They have lots of androgens. So they're going to have ambiguous genitalia at birth. If a person is a female, if they're 46XX and they're a woman, they're going to have ovaries when they're born, but because of the increased amounts of androgens, they're also going to be partially masculinized. So they're going to have virilization. They're going to look a little bit like a guy, sort of. It's pseudo-hermaphroditism. What's the definition of this? Born with primary sex characteristics of one sex, but develops the secondary sex characteristics that are different from what would be expected on the basis of the gonadal tissue, ovaries or testes. So this would be a person born as a woman, 46XX, but they kind of have an enlargement of the clitoris, which looks like a pseudo-penis, effectively. So this would be ambiguous genitalia, which is associated with congenital adrenal hyperplasia, 21-hydroxylase deficiency. So what do you see with hypersecretion of estrogens? If you have too many estrogens, you're going to get feminization. You're going to develop secondary female sex characteristics. If this is on a guy, you're going to see gynecomastia. You're going to see breast enlargement. For their testes, they're going to be atrophied. Libido is going to be low, right? So you're going to have feminization of this individual. If they have too many androgens and it's a woman, then that woman is going to experience virilization. They're going to have increased male sex characteristics. So they're going to have hirsutism, which is, facial hair in places that they doesn't belong, like a mustache. They're going to have sideburns, things like that. They're going to have acne. They're going to have clitoral enlargement, so it's going to look like a pseudopenis. They're going to have deepening of the voice, amenorrhea, so lacking menses, and their breasts are not going to properly develop. So those are things that you would see with 21-hydroxylase deficiency. Okay, let's move on to the last section of our talk, and we're going to discuss pheochromocytoma. So pheochromocytoma is going to be a tumor that affects the adrenal medulla. Now remember, the adrenal medulla, that's in the middle of the adrenal gland, and that's what produces your catecholamines, epinephrine as well as norepinephrine. If you have a tumor that affects the adrenal medulla, you're going to see pheochromocytoma. You're going to see excess in the production of these catecholamines. This is equal between men and women, and usually it happens, around 40 years of age is going to be kind of the average onset. Mostly benign condition, but it can be malignant in certain conditions. And you're going to see episodic hypertension. It comes and goes. It's paroxysmal. So you're going to see diaphoresis or sweating. The person's going to have hypertension, so they're going to get headaches. Their heart rate is going to go up because think about epinephrine, norepinephrine. Catecholamines, when they attach to the beta-1 receptors in the heart, causes tachycardia, accelerated heart rate, and contractility. You're going to also get palpitations. These people are going to feel really stressed out. They're going to experience anxiety. They're going to lose weight. It's going to look a lot like hyperthyroidism, right? But it's going to be at the level of the adrenal medulla. How do you test for this? You can test for serum metanephrines as well as vanilla mandelic acid, or VMA. VMA is going to be high both in the blood serum as well as in the urine. And then if you did a CT scan, you should be able to see a growth or a mass at the adrenal medulla. So let's kind of overview here what epinephrine and norepinephrine do. It's involved in the fight and flight response. So these people are going to experience all sorts of things. Heart palpitations. They're going to experience sweats, chills at the level of their skin. They're going to have changes in salivation. It's going to be decreased. Pupils are going to be dilated, right? Because think about adrenergic activation of the ciliary muscles in the eyes. You're going to get dilation of the pupils, right? Fight and flight. Heart rate goes up. Bronchodilation, so you can breathe rapidly. You're also going to have pupillary dilation, so you can see the things that you're, trying to watch out for. That's the whole sympathetic fight and flight response. Bowels, you're going to get constipation, because think about fight and flight. It's the opposite of rest and digest, right? So you're not going to be having gastric motility or motility of the GI tracts, right? So you're going to get paresis and constipation. Blood vessels are going to be constricted because alpha-1 adrenergic effect cause vasoconstriction, and your muscles are going to be very tense as well. So one of the last slides I have here is the biochemistry of epinephrine and norepinephrine synthesis. Starts with tyrosine. Tyrosine eventually, with tyrosine hydroxylase, turns into DOPA. DOPA decarboxylase turns that into dopamine. Then you have dopamine hydroxylase turning dopamine into norepinephrine. Then eventually you get epinephrine at the end of that cascade. When norepinephrine and epinephrine is in extremely high amounts, they're going to get broken down, and the end product of breakdown of your catecholamines is vanilla mandelic acid, or VMA. So that's what you can test in both the serum as well as in the urine. And then I have some images here that show both a autopsy by cross-section of the kidneys as well as the adrenal glands. In the adrenal gland, you can see this massive tumor in the adrenal medulla. There's also a CT scan here. If you're not a radiologist, it's kind of hard to tell what's going on there, but it's above the kidneys. You see the adrenal gland, and you can see a large mass on the CT scan, which is going to be characteristic of pheochromocytoma. And that basically does it for our series on endocrinology. Thank you, and take care.